I'd like to talk to you about an exciting new technology for the treatment of aortic stenosis called transcatheter aortic valve implantation, or TAVI. During this presentation, I'm going to discuss aortic stenosis, the indications for TAVI, assessment of patient suitability for the procedure, different techniques used in valve implantation, and finally, review our UK TAVI registry data. In a normal aortic valve, the valve area is between 3 to 4 centimeters squared. The commonest causes of aortic stenosis at valve level are rheumatic valve disease, calcific stenosis within a tri-leaflet valve architecture, or superimposed calcific changes in a congenital bicuspid aortic valve. Symptoms of aortic stenosis include angina, dyspnea, and syncope. Signs are a slow rising pulse and an ejection systolic murmur. The signs of severity, as evaluated by clinical examination, have been shown to correlate poorly with actual severity documented at echocardiography or in the catheter laboratory. Echocardiography grades aortic stenosis into mild, moderate, or severe based on a variety of parameters as shown on this slide. In severe aortic valve disease, the effective orifice area, a measure of how widely the valve leaflets open, is reduced to less than 1 centimeter squared. Surgical aortic valve replacement is the established gold standard treatment for severe AS. There is a long latent period before symptoms appear in aortic stenosis, and when they do appear, prognosis is poor. However, those referred for AVR don't always undergo this invasive procedure, as these 5 studies show. The reasons that they do not undergo surgery include high surgical risk conferred by advanced age and multiple comorbidities. Therefore, there has been an interest in developing less invasive transcatheter technology. The first transcatheter aortic valve was implanted in France by Alain Cribier. 5 years later, the first procedure was performed in the UK at Glenfield Hospital. By 2010, the UK had seen greater than 1,000 procedures performed. Towards the end of 2010, results of the partner trial, Cohort B, were published in the New England Journal of Medicine. This important study showed that in patients unsuitable for surgical AVR, the transcatheter TAVI option led to a significant reduction in mortality versus standard treatment. So, the current indications for TAVI are severe symptomatic aortic stenosis in patients for whom the risk-benefit ratio of open heart surgery versus TAVI is considered to favour the transcatheter option. Assessment of patient suitability hinges on the multidisciplinary team discussion. The MDT consists of 2 cardiothoracic surgeons, 2 interventional cardiologists, cardiac anaesthetists, and cardiac imaging specialists. Imaging workup pre-procedure includes TOE, which is transesophageal echocardiography, and cardiac CT. CT assessment for evaluation of the femoral arteries allows the team to decide upon how best to deliver the new aortic valve. The preferred delivery route is the transfemoral approach because this is associated with the lowest rate of complications. The patient in our case underwent the direct aortic approach. Now let's look at some UK TAVI data. Up until 2012, a total of approximately 4,000 procedures had been performed. In 2012 itself, the number of devices implanted was around 1,300. Our graph here shows a steady rise in implantation rates year on year. UK TAVI centres and number of procedures performed per centre are shown on this slide, with the Queen Elizabeth Hospital highlighted in red. The average age of TAVI patients is 83, with patients who are unsuitable for the preferred transfemoral approach having higher rates of peripheral vascular disease, coronary artery disease, and prior CABG. Stroke is an increasingly rare complication, as shown here. In conclusion, aortic stenosis is an increasingly common and important pathology. Transcatheter aortic valve implantation is less invasive than surgical AVR and is rapidly becoming the preferred treatment option in high-risk patients.